Hi, everyone. Welcome. Good evening. We're super excited to have you here with us tonight. We're going to give just a couple seconds here to kind of give people time to sign on, and then we'll get going with our exciting event tonight. Okay, it is officially 7:02. Welcome everybody to this joint endeavor between the Society for Vascular Nursing and the Association for the Advancement of Wound Care. This is really exciting to have both organizations here, as well as to welcome our featured guest speaker, Dr. Alabi from Emory. As far as our speakers and moderators go today, we have some really great experts on this call. We hope to have some really robust discussion. So starting with Kristen Alex. Kristen is the current president for the Society for Vascular Nursing. She works as a nurse practitioner at the University of Colorado in the Division of Vascular Surgery and Endovascular Therapy. She started her career in critical care and interventional radiology, but subsequently fell in love with vascular surgery. She pursued her career as a nurse practitioner in 2003 and then went ahead to continue her education and got her acute care certification following that. She currently works in multiple settings, inpatient and outpatient at Colorado University. She's had some amazing mentors. She's an amazing leader, wonderful president for the SVN. We're super excited to welcome Kristen tonight. We also have Kara Couch with us, another well-esteemed expert in our field. Kara is the current president-elect for the AAWC. She graduated with her Master of Science in Nursing from Georgetown University in 2002. She's currently the director of wound care services at the George Washington University Hospital in Washington, D.C. She's an associate research professor of surgery at the School of Medicine and Health Sciences. She's the current co-chair of the Alliance of Wound Care Stakeholders. And like I mentioned, Kara is also the president-elect for the AAWC. We are also super excited to welcome Dr. Alabi tonight, our featured guest speaker. I'm really excited to hear what Dr. Alabi has to share. Dr. Alabi received her medical degree from the University of Nebraska College of Medicine. She trained in general surgery at Loma Linda University Medical Center in Southern California, and then completed a fellowship in vascular surgery at Oregon Health and Science University. She has a high appreciation for multidisciplinary collaboration and clinical program development. This began at OHSU and was particularly expressed in her work to improve surgical outcomes in vascular reconstruction during oncologic surgery. Her leadership of several systems level quality initiatives, including the development of clinical protocols to fast track endovascular abdominal aortic aneurysm repair at OHSU's aortic center. So again, a breadth of knowledge and experience from Dr. Alabi. Her clinical expertise ranges from PAD, carotid disease, as well as the management of acute and chronic aortic disease. So Dr. Alabi is here to talk with us tonight about the socio-political determinants of PAD care toward health equity. Welcome, Dr. Alabi, and Karen and Kristen.
Hey, thank you. Can you all hear me okay? I'm just going to give a quick introduction for our societies, as will Kara, before the talk. I am so excited to be partnering tonight with members of all the other societies. The Society for Vascular Nursing was actually formed in 1982, and we are a professional community for vascular nurses and advanced practice professionals. We have PhD researchers, can't talk tonight, talked all day, did fine. And then we also have nurse leaders in our organization. And we are very proud to take care of people with vascular disease through excellence in evidence-based practice and education. We are a small society, about 300 members. And one of the things that I am passionate about is the education of nurses and of our patients. And one of our goals this year was to put on these events to have every month for nurses to join and help take better care of the patients. And we couldn't be more excited to have Dr. Alabi and Kara on tonight. And thank you, Karen, for the great introductions. So I'm very excited to hear, and I'll turn it over to Kara.
Thank you, Kristen. Sorry, I couldn't find my mute button. Can you guys hear me now? Okay, perfect. So AEWC is the Association for the Advancement of Wound Care. We are the largest multidisciplinary wound care society. We have physicians, nurses, advanced practice providers, OT, PT, RD. I'm forgetting somebody, and this is terrible. Obviously our physician partners, but really a great group, and we love working on events like this. We feel that education is our strong suit. And so this is just a slam dunk for us to have this amazing platform to work with the SVN again. And we will be having another great webinar in November, October, the International Skin Tear Advisory Panel. We're having a collaborative skin care webinar. So we will be advertising for that. And if you have any other questions, happy to take it in the chat. Kristen and I will be moderating that after Dr. Alabi's amazing talk. So with that, I will turn it over to Dr. Alabi. Thank you.
Thanks, everyone. I'm really excited to be here with all of you tonight. I'm going to go ahead and get my slides up. Hopefully everyone can see my slides.
We sure can.
Okay, perfect. Okay, good. So my name is Olamide Alabi. I'm a vascular surgeon at Emory University Hospital, as well as at the Atlanta VA healthcare system. And I'll be sharing with you a little bit this evening about peripheral artery disease, specific to how it relates to health equity and quality. So these are my disclosures. There are no financial conflicts of interest, and the outline for the talk this evening. So as you all know, I'm in a Zoom room full of vascular nurses, enthusiasts, aspirants, maybe even some patients, hopefully, and physicians. And there may even be industry representatives. I think some told me that they were going to log in and check it out, but I don't need to read these statistics to you. In short, peripheral artery disease, or PAD, it has a high prevalence, and it represents a high cost burden in the United States healthcare system. That prevalence increases with age, and the proportion of women with PAD is not insignificant. There are several known risk factors for PAD, as you can see on this non-exhaustive list here, and we typically concentrate on those that we know quite a bit about. So age, advanced age is a risk factor for PAD. Smoking status, diabetes, chronic kidney disease, etc. And we've identified race as a risk factor for PAD, as well as subsequent lower extremity amputation for many years, for decades, in fact. However, we have no idea why that is, particularly since race is a social construct, and we haven't been able to really scratch the surface along that line of inquiry thus far. Black patients, they have the highest prevalence of PAD in the United States, and compared to Black women, brown women are a close second in all age groups. So as far as outcomes go, Black patients are treated differently when they present with symptomatic peripheral artery disease, and they experience worse outcomes related to their peripheral artery disease as well. So why does any of this matter? So not exclusively, but PAD is a disease of older adults, people who are already typically frail, have other chronic comorbidities, etc. And there are over 185,000 major amputations that occur every single year. And nearly 2/3 of these amputations occur in people who are diabetic. and just under half, so just under 50% of those individuals are also of non-white race. So this means that there are populations of patients with symptomatic PAD who have a risk of limb loss that ranges anywhere from a number that's relatively low to a number that's relatively high, and simply because of who they are and where they live. So you kind of think, well, how do we even fix that? Like, where do we start? Well, I believe it starts with a firm understanding of what race is and what race is not. So race is a social construct. For all intents and purposes, it's made up. So the question is, what does race represent? What is race a proxy for, if you will? And many experts would say race is a proxy for racism. And I would say, well, they're not wrong. And I'm sure now everybody also is familiar with the concept of social determinants of health. So many people would say that race is actually a proxy for various social determinants of health. I'm sure everyone on the call is familiar with these topics, and I won't belabor this point, but the social determinants of health need to be leveraged so that we can create change. So the political determinants of health, I'm going to spend a little bit more time here because this is a concept that most people are not exactly familiar with. So the political determinants of health are the creators, exacerbators, and perpetrators of very specific structural conditions, and they are arguably the factors that continue to drive health inequities to this day, or health disparities to this day. For example, in the 1600s, policymakers and business leaders together, they created these facially discriminatory policies that explicitly prohibited Black and Indigenous people from raising their own food, from earning their own money, from learning to read or write, from moving more than a mile away without a permission slip, from socializing or worshiping or playing in unsanctioned areas, etc. And these policies distributed resources, they allocated power, they sanctioned neighborhood disinvestment, and they structured relationships that have created and fueled health inequities to this day. And policies such as these determine where factories with hazardous waste go, where factories with air pollutants go, where highways are built, where railroads are placed, where fast food restaurants are placed, and where Whole Foods is not likely to be placed, and where people who are phenotypically very similar to me, where they live in relationship to those things. And we never really like to talk much about bias when we mention racial disparities in healthcare, because we'd like to believe that we provide the same level of care to everyone who comes. However, one has to understand that that's not exactly the case. So bias can occur at various touch points within an episode of care. And before a patient can even make it to an encounter for care provision, they must first trust the system and the providers therein to seek that care, right? And so we know that, understandably so, several members of the Black community do not trust the healthcare system. And this is not limited to just the Black community either. We also know that when you go to an ER or to a clinic, or you're on an inpatient ward and you have pain, someone has to believe that you have pain so that they can help work up your pain and then treat your pain, right? And it's clear that minoritized patients are often not believed or perceived to have pain as much pain as they describe. Although we have not specifically studied this may contribute to why patients with claudication are diagnosed with spinal stenosis or hip osteoarthritis and a myriad of other musculoskeletal diagnoses before they get a diagnosis of claudication or a diagnosis of peripheral artery disease from a vascular specialist. And good luck not getting passed over in the ER if you have a problem that warrants emergency department evaluation. So this is quite a novel study, and it had some what I would describe as profound findings. So this article stated that patients who were non-Hispanic Black, Hispanic or Latino, Spanish speaking, or insured by Medicaid were more likely to be jumped over in the queue for evaluation within the ER. And patients who were jumped over in that queue had higher odds of hallway bed placement and leaving before treatment is complete. One thing I will note in all these studies that I flashed on this screen for these last few slides is that none of this work is specifically about PAD patients because, well, nobody's really studied these themes in PAD before, not really. So it was in starting my first job after fellowship that I realized my passion for improving quality and particularly in PAD care. And since I see disparities as the greatest threat to quality, I've made it my mission to understand and work towards the elimination of racial disparities in PAD care. But I do want this to be a bit more personal. You know, folks on this call, we all know the data. We often present this data, not just us, but everyone, present this data and patient stories from a very high level view, or even sometimes an us versus them perspective. But these categories are communities. These patients, they have faces, they have families, they have friends, they have futures, they want to have futures. And many patients who, again, are our neighbors, our family members, and our friends, they fall victim to poor quality care. So I'll tell you a few stories, since I want to make this a little bit more personal. So my parents, this is my first example. They are Nigerian immigrants who came to the United States in the 1970s. My father, he came to obtain a degree, a PhD in agronomy, and my mother, she obtained a master's in social work. They came for an American dream, but oftentimes were only offered American nightmares. And through watching their experiences navigating a healthcare system that often saw them as things that they were not, such as uneducated, non-English speaking, unfunded, health illiterate, maybe even just illiterate completely, non-compliant, etc., even when they weren't any of those things. So these experiences and more, they initially primed me to be on the defensive when caring for patients. And thankfully, additional experiences and people I've met along the way and who have kind of inspired me throughout my surgical training taught me more than anything that the best defense is a good offense. And I learned actually most of that from patients. So let's take a little step back and demolish some of this us versus them and put some faces to a story as it relates to PAD. So again, I'm a first-generation American, and this screen left is my father. He is a Nigerian immigrant. He came here to Nebraska, actually, of all places, and that's where he got his PhD in the 1970s. Here he's standing in line with my brother, who after he became a U.S. citizen, my father, it was just in time to vote for the 2016 U.S. presidential election. And I had to remind him that when I voted in my first U.S. presidential election, my candidate didn't win either. But when he immigrated here, my father developed a very close friendship with a Haitian immigrant who is the father of my best friend. That's us in the middle. So don't mind the flip phone that's partially seen in my hand there. That's a picture of us on a Spirit Airlines flight. It was a very long time ago. We don't suffer from that same economic insecurity that we used to. But during our trip, my best friend's father was hospitalized. He felt very poorly. He checked his blood sugar. He noted it to be quite high, and he went to the nearest emergency room. So this emergency room happened to be in Lincoln, Nebraska, because that's where we all lived. And so he's a civil engineer with 2 PhDs. He noticed a very small wound on the outer portion of his fifth toe where his boots rub against his foot. And during this hospital admission, he was offered management for his hyperglycemia. And at some point, he was also offered a major amputation. And upon further discussion with him, they stated that the small dry wound on his toe that had no signs of infection, no underlying osteomyelitis, that this was the cause for his hyperglycemia. And in order to definitively treat this hyperglycemia, they would need to remove his entire foot. And thankfully, he refused. He called us, and we also refused. And long story short, no one ever checked a pulse. No one ever did an ankle brachial index. There was no CT scan, no MRI, no angiogram, nothing like that. There was just, we need to remove your leg. And I want to tell you guys, the only reason that this story is uncommon is because he refused. That's unfortunate. So what can be described as a lack of compliance in PAD care? We've seen it. It's non-compliance, right? People talk about it all the time. Oh, this patient had this bad outcome because they're non-compliant, et cetera, et cetera. So in PAD care, what are some ways that this can look? We know that statin use can reduce the need for amputation with relative risk reductions between 18 to 35% that were not seen with non-statin lipid-lowering therapy. And we also know that patients from Black and Brown communities who are candidates for statin therapy largely don't get it. There was this one study at University of Michigan where they said rates of statin prescribing were 62% lower in Black patients with a high atherosclerotic risk score compared to white patients with a high atherosclerotic risk score. So it's not that patients from these communities are non-compliant with statin therapy. By and large, they are not prescribed or offered statin therapy. And we know that once diagnosed with a mild manifestation of PAD or claudication, the evidence-based treatment is guideline-directed medical therapy and the prescription of exercise therapy. We also know that Black Americans with PAD suffer a greater degree of functional decline over time, and this may be related to less access to exercise in their communities as well as socioeconomic status. we're learning that supervised exercise therapy has a greater impact on quality of life among Black Americans compared to non-Hispanic white Americans. But again, Black and brown communities are not prescribed supervised or home-based exercise therapy at the rate that non-Hispanic white patients with PAD are. And to be honest, altogether, most people are not prescribed exercise therapy at the rate that they should be. So Black patients also suffer from overutilization of revascularization procedures when they present with mild or early manifestations of PAD, maybe even sometimes when they're not quite indicated, but they suffer from a lack of utilization of these same revascularization procedures when they matter most, when they present with end-stage PAD or chronic limb-threatening ischemia. So Black patients are also more likely to undergo above-knee amputation compared to below-knee amputation, which has significant implications on future prosthetic fitting and subsequent ambulation, and very well may contribute to early mortality in these patients. So I went to a conference recently, and the keynote speaker, he had very sage advice that was actually quite simple. He said, I'm kind of extrapolating this to say, specific for deconstructing noncompliance. He just said, look, listen, and feel. We need to look at our patients in the eyes. We need to listen to what they're saying and to what they're not saying. And we need to perform a physical exam, which apparently is a lost art. We need to get rid of these concepts of non-compliance and lack of adherence, and both identify and then challenge our biases that we hold about the patients that are coming to us. It's okay to ask questions. I ask a lot of questions. You probably could ask anybody. I ask probably too many questions sometimes, but like, where do you live? How far away is it? Like, what's the actual drive time? How long did it take you to get here? If you have to leave clinic because we're running behind, what does that drive time look like in traffic, at rush hour? How did you actually get here? Did you drive yourself? Did you take MARTA mobility, et cetera, et cetera? And also I ask questions like, oh, so I noticed that you have a statin medication noted on your medication list. Do you take it? Oh, you don't take it? Well, why? What did you hear about it? First, I like to really provide credence to their concerns, whatever those concerns may be, and try to debunk the myths that they may hold about that particular medication or other medications that they should be on. And then I also like to try to put things in perspective, not trying to scare anyone, but we know that statins save limbs and save lives. So you should be on one. Access means several things, and it's more than just getting a diagnosis and getting someone in the door to see you. You can be plugged into a primary care physician without getting specific wound care. You can be plugged into a primary care physician or a podiatrist without getting specialty care to address your vascular disease. And you can even be plugged into a vascular surgeon or a vascular interventionalist without getting a revascularization, which obviously is a complicated bag. And from articles like this, I'm not going to go deep into this, but patients are losing our trust. This is what this article said, blaringly to me. And, it's just a further reminder that as interventionalists and as providers in this field, we're not on the same page. And more importantly, we're not on the same page with our patients. And the public, which includes our patients, they're demanding more from us. So what have we done about this? We know that there are studies that say that gender concordance and racial concordance are good for patients, are good for outcomes, are good for satisfaction, et cetera, et cetera. But what have we really done about it? And I could say, to be honest, not very much. Our workforce and our pipeline don't reflect the US population. And it behooves us to be more intentional about recruitment and hiring decisions, be more intentional about creating sustainable retention strategies, and sponsoring, promoting, and supporting our students, residents, and fellows and faculty who are underrepresented in medicine and in surgery, and in the workforce at large. So representation matters, and it really does start from this age, trying to gather interest in people who may not have been exposed to our field before. So I'm happy to take any questions from the audience. I just wanted to know, particularly some of the things that were discussed in this talk today, deconstructing noncompliance, optimizing access to PAD care specifically, and diversifying the PAD workforce. What are your guys' thoughts? I think that there's strength in numbers. I think that there's strength in leveraging our own collective community, and then also leveraging our patient and patient caregiver communities so that we can all come together and create change.
Wow, thank you. A lot of powerful slides you just presented in a wonderful way. One of the things that resonated with me when you talk about the art of the physical exam, that was lost. And I will see patients in my clinic for a fistula. And if it's the first time I see that patient for a fistula, I'm listening to carotids. I'm feeling for pulses in the radials. I say, take off your your shoes. We're going to look at your feet. And we're going to look at both feet and look in between their toes. And then I always ask them before they leave how their walking is. And I think one thing I learned as a new NP, or even in anything, any of our RNs do this. If you have a standardized vascular exam that you do, you will find something. You will find carotid bruits. You will find decreased pulses. And you need to follow those up. I mean, I can't tell you how many patients I have come in for ABIs, and that leads to longer conversations about how they're not able to walk at their house, or not able to do their jobs, or stairs are a real chair, hard for them. It's a systemic disease. And if we're not looking at the systemic disease, we're not doing our patients justice. So that was one of the things that really resonated with me, among many others. But let's take any other questions.
Yeah, definitely PAD is the gift that keeps on giving, for better or for worse. So you got to keep looking.
Dr. Alabi, that was incredible. I have like 7,000 thoughts going through my brain right now. I think that something that I have really internalized, I'm 20 years into my practice as a nurse practitioner in wound care, but certainly a vascular exam is the hallmark of wound care, because without blood flow, we can't heal these wounds, right? Mm-hmm. And I work a lot in limb loss. And I think that the labeling of non-compliance without investigation to the reasons cannot be underemphasized, and that we have to get away from that term. So what are some strategies that you can offer us to educate other, people that work in our clinic, other colleagues, people like that? I think that would be super valuable to get away from the nons. I hate the nons.
Yeah. Yeah, no, great points. Great question. I remember in fellowship when I was at Oregon Health and Science University, I mean, we actually, I guess you could say, divorced ourselves from that word non-compliance, because there's always something behind this, quote unquote, lack of compliance. Perhaps you have prescribed someone a DOAC for a DVT or for a PE or for whatever, reasons that we use DOACs for. And imagine that you prescribe this for this patient who might be insured, but their insurance doesn't cover it. And so now they show up at the pharmacy once they've been discharged, and they say, oh, okay, it's $1,800 a month. I mean, who can pay for that, So I think when people are being faced with choices where they're choosing between, can you eat this month, or do you have to take this medication? Can you pay your rent? Can you pay your mortgage, et cetera? Can you pay your car note? All those things. Or can you take this medication? It's really hard to say yes to that small pill when you got to live somewhere, right? I think that label, non-compliance, and particularly seeing it in someone's chart, it can do a lot of harm to a patient. Again, there are patients who are asked to take statins, and they may be hesitant. They may be hesitant for reasons that we think are, relevant, and reasons that we think are not relevant, but they're relevant to them. And I think that's the most important thing, is you have to kind of meet people where they are. It doesn't matter what you think, it matters what they think. And if you want to get them on board, you got to get down to where they are and try to figure out what's going on. And it starts with asking questions.
That's so true. I think that one of the lessons I learned after probably 5 years of practice was not all patients, sorry, not to keep diverting to wounds, but not all patients expect their wounds are going to heal.
Yeah.
And if you don't ask the patient, what do you want out of this process? They may want it to just be less painful. They may want it to just have less odor and drainage. So they can go to church on Sunday, or go be like a normal human. I do want to just encourage everybody to put questions into the chat box, because we have such an amazing, font of knowledge here. We need to make sure that we get our, the maximum amount here in our time together. But I think that is like super clear. And I also wonder about how we are teaching these topics in our medical schools, in our nursing schools, in our residency programs. There has been a lot of focus on socio-political determinants of health, things like that. But I think that, some of the studies that you provided were really stark And we can use those, and we should all use those in our education for, to just make sure that everyone understands the gravity of what we're dealing with.
Yeah, no, I completely agree. And I think there's still a lot of work to be done in terms of educating people, providers, about the social determinants of health as well as the political determinants of health. And I think, it's one thing to learn, these things. Here are these factors. Here are these things that I need to look out for. It's another thing to understand, how do they actually reach patients? Just because someone has a specific grade level education, or no grade level education, or perhaps even a postdoc level education, that doesn't mean that they're health literate. So that, trying to get down to the root of, what do you understand? When I come into a room and say, you have this wound, you have peripheral artery disease, this, as you guys mentioned, this is a systemic disease, and you're just like spouting off all these things to the patient, and they're kind of like, wait, what? I came in here, I thought I was gonna get like betadine or something for my toe and get out of here. Like, what are you talking about? What are all these things? And we've got to make sure that we're getting to the heart of what's actually going on and how we can actually reach people. If all people are thinking about is, I drove 2 hours to get here, and you were late, you're running like an hour late in your clinic, and I'm going to be in rush hour, it's going to take me 3.5 hours to get home. It's really hard to digest that information. So we got to make sure that we're getting on the same page with people, and also following up with people.
Yeah, I think that's really important. One thing I wanted to point out is someone had mentioned the Q&A box is live, but the chat has been disabled. We're trying to work on that. So if you have a Q&A box, you can put your questions in. Please go ahead and do that. I think absolutely what you said about people, worried that you just were going to get betadine and you get a whole spiel. One of the things that I have done is I've made a flip chart of photos and diagrams and pictures of everything I can think of, from lymphedema to venous disease. And we've even started to put PAD related. We have PAD diagrams on our website now that we're trying to get to the Society for Vascular Surgery to share. So we can draw pictures, because you're right. We can't assume that everyone has, this higher level education of what peripheral artery disease is. And if you just show them a diagram, it relates to someone with, who may not have the same language as you. I've had a woman from Jamaica come in, and she could not afford her Voyager trial Xarelto, and she didn't trust it at all. And I was really stymied as a provider who, didn't look like her and who she didn't trust, to help coax her along to get this Xarelto that would help the microvascular disease that she had. And we ended up trying to follow up with her, even with social work, to go out to her house and say, what barriers do you have for this? And, can we do it? And we eventually found out her son said he couldn't afford it. So there were some chats in here. Nikki Taylor said, what are your thoughts on how we make sure that we have representation of our healthcare community in our PAD population?
So our healthcare community as it relates to our PAD population, like mirroring or improving the representation that we have there? Is that what the question? Okay. Yeah, I think it's absolutely essential. I think about, so this is not a lower extremity peripheral artery disease trial, but I think about CREST-2. So I know some of you guys are familiar with the CREST-2 trial is going on. We're trying to determine if carotid artery stenosis, if patients are better served with optimal medical therapy, or if they're better served with a carotid artery surgery, whether it's a stent or an endarterectomy, etc. And so that trial is international. It's going on. All these people are really excited about what this stuff is going to show. But what we have noticed is that we weren't enrolling any Black patients. And I live in Atlanta. Atlanta, the population is over 30% Black. How are we not enrolling Black patients? Definitely Black patients come in and they have carotid disease, whether they're symptomatic or asymptomatic. This is an asymptomatic trial, but we have both of these pockets of patients coming in from this community, but they're not enrolling in this trial. And it was not for lack of trying, is what I would say. But we significantly increased our enrollment in the CREST-2 trial, really just with hiring me. They didn't hire me for that purpose. But, for me sitting down and talking to them and saying, here's what the trial is, here's what your problem is, your disease process is, and here's why I think it's important for you as a Black woman. This is why I'm telling you as a Black man or a Black woman, why I think it's important that we are in clinical trials. And you know, my father has given me, access to be able to give his story. So I talk about, you know, different trials that he has been a part of because of the medical problems that he has, and why he feels like it's important for him to engage in that way. And we all know that representation in clinical trials is low. The workforce, it's also low. And we have to be able to improve those so that we can improve that number for everyone, and determine if these results that we're getting from these international, national, regional, local trials that we're doing are even generalizable to Black and Brown communities or Native American communities, for example.
Gotcha. Kara, can you see the questions as well, or should I just keep reading them?
I have to unmute myself, don't I? Yes, I can see them as well.
Okay, why don't you take the next one from Eileen?
Yes. So this question is from Eileen Self, and I apologize if I didn't pronounce that correctly, but this is a great question. Can you elaborate on structured, non-independent exercise programs?
So structured, non-independent, is that what you said?
Yes, structured, non-independent exercise programs.
Yeah, so you know, exercise therapy for peripheral artery disease, this is mostly for the more mild manifestations, claudication. You know, exercise programs, we know that they work. We know that if we put people in a program where they will walk at least 30 minutes a day, at least 3 times a week for 12 weeks, we know that they can improve their walking distance and have pain at a further walking distance, or some people can even get rid of their pain, maybe because they walk so far but don't walk enough to have pain anymore, kind of thing. So we know that these work. We also now, thankfully, for the work that's been done by Diana Treat Jacobson, by Mary McDermott, etc., we know that these exercise programs can be given in the form of structured exercise therapy. So it's like cardiac rehab, like a very structured environment, and you're at a facility. In unstructured environments, so we don't have a lot of these physical therapists who do structured exercise therapy in my communities. So what we typically say is, I know that you live near Piedmont Park. Piedmont Park is a relatively safe area to go for a walk. You can do an unstructured supervised exercise therapy in that location. We also know that home-based therapy works as well. And that home-based therapy can be unstructured, again, as mentioned, or it can be structured with a physical therapist. Now, there are more and more physical therapists that are getting on board with structured exercise therapy as part of their regimen for care, specifically when it's ordered in that way to be structured exercise therapy for peripheral artery disease. A lot of cardiac rehabs are also getting on board with that as well for their patients who also have concomitant PAD. But we're still a long ways away for it being, down the street like a Walmart, everybody's not in a community where you can get it in a structured fashion, but certainly there are unstructured ways in which people can still gain benefit. Hopefully that answers the question.
Yeah, no, that was a great representation of exactly what we talk about. If you have a program, go ahead and do it, like a structured program that, Medicare and Medicaid are paying, or Medicare are paying for now. But if you don't, it's just a time or distance. And you said it very well. Marie Topping asks, what is your best recommendation for patients who are fearful of taking statins due to concerns of myalgia? Good one. I feel that I have difficulty trying to educate patients, especially those with family in the medical field, who automatically advise against them or refuse them due to risk for myalgia.
So these, interestingly enough, are some of the hardest conversations that you have to have. Sometimes it's even harder than trying to convince somebody to quit smoking, or at least try to quit smoking. And, nowadays, I would say, what I typically do is I start with, why do you not want to take it? And we just kind of unpack what exactly that is. And I would say for most patients, this is just in my practice, anecdotally, for most patients that I meet who kind of are initially hesitant to take a statin, it's usually because they heard a friend of a friend had a problem. It's not that they had a previous problem. It's not that their direct contact, neighbor, friend, family member had the problem. It's like this thing that I heard, right? And you're kind of like, is this even real? I don't really know. I'm not really sure what to do with this, but you got to give credence to what they're saying. And you can say, yes, that does happen, but it happens to a very, very, very infrequent number of patients. And, comparatively, I think it would be better because we know how important these medications are. We know how beneficial it would be for you with your PAD diagnosis, both for limb salvage and for life salvage, right? So I think we need to put it in perspective. And how about, let's meet somewhere in the middle. Can we start a medication that has a lower chance of having myalgia and start at a very low dose? Maybe it's not high intensity statin just yet, but maybe we can work our way up there. And I would say the vast majority of patients will get themselves on board for something like that. But it takes a lot of time. You know, this is an encounter that you're sitting there with patients and explaining all this and listening with them for quite a while. But it takes that investment, I think, with this, particularly with this disease process. It takes that investment.
Yeah, Kara, one thought before you ask the next question is, I always talk about the secondary benefit of plaque stabilization. And once patients see the amount of plaque on their CAT scans, you can be like, well, it'll keep this from getting worse. And nobody really realizes the second benefit. They just think it's going to lower their cholesterol. So a lot of education, like you suggest.
Right, absolutely.
Yeah, no, that is like super critical. I think that the more that we can actually show the patients their studies and their images and break it down for them, that they get kind of a buy-in, because otherwise it's kind of this nebulous idea that it's just kind of like out here and they don't really understand internally how it impacts them until they do things like lose limbs, and then it's all too real for them. So Diana Eastridge has a great question about how has and I hopefully I'm phrasing this right. The health disparities seem to be increasing, not decreasing. Have you seen improvement over the past 20 years? Basically, are we doing better or are we more aware and doing worse? I believe I interpreted that right.
Yeah, that excellent question. I would say, at least based on the data, it does not seem that we are doing worse, but we are certainly not doing better. And I would just say, all in all, we're doing pretty poorly, is what I would say. All comers, if you look at Medicare data, if you look at Cigna data, if you look at Optum data, if you look at VA data, the rates of amputation in the Black community are 2 to 4 times that of non-Black communities or white communities. And that's any population that you gather. It doesn't matter what data set you have, that's what you're going to find, unless you have a data set that doesn't have any Black patients, right? So, I think that the answer is it's bad. It's really bad. It may not be necessarily worse, but it's still bad, is the way I would say it. I wanted to bring up something about this showing patients their imaging studies. It's certainly not something that I was taught in training or trained to believe was important to patients, but certainly in practice, I have found it's extremely important to patients that you do that. And another thing that I've also found is that they seem to like, when I actually draw out like an arterial tree for them or something like that, I might be talking about an infrarenal abdominal aortic aneurysm, but if I start with a heart and, something that they can look at and say, I know what that is, and then draw an aorta and then show some branches that go here, here, and here, and then we come down to the abdomen, et cetera, et cetera. And it's like a light bulb comes on. Whereas, when you're looking at a coronal view on a CT scan, they're kind of like, I don't really know exactly what I'm looking at, things like that. So I think that there's a lot to be said about sharing with patients more information than they probably would have been shared, in the past with them.
Can I do a shameless plug for Society for Vascular Nursing? One of my great mentors created diagrams for all his patients. And he did this on probably a DOS system years ago. And he would give every patient that he'd have femoral tibial bypass on a picture of their diagram. And the patients would carry it around. And if they were in Florida, vacationing and their bypass went down, they could just go to a doctor and say, here's what's going on. And we at the Society for Vascular Nursing, I think this is so important. And we've replicated this with blank diagrams, like I was saying. And my goal would be to have those pictures actually be in the chart. So if Dr. Alabi, you had done some fantastic, reconstruction that was endovascular and open repair, you basically draw on it what you had done, and a picture said 1,000 words. So like, you couldn't speak more to my like heartstrings when you say that. And showing patients after they've had an EVAR repair or their CAT scans, they have these 2 small pokes and then they go, you didn't do anything. Well, here's all the structure inside of you that proves it. So we have another question, and I'm just going to open this up because I want to make sure I get, it's Catherine. I can't see your full last name, so I'm just going to say Catherine N. She says, I love the real life analogies. What a great presentation. I agree with meeting patients where they are. Any suggestions of words to use instead of non-adherence? I am veering away from non-compliance, but would love some ideas of words to use if they are truly non-adherent with medication or treatment plans. Great question.
Yeah, that is a great question. I've pivoted from using, I guess, just one word terms to just describing what the patient told me. So sometimes you'll find, maybe you'll find the non-compliant with antiplatelet therapy or non-compliant with DOAC or non-compliant with the statin somewhere in their chart. And I just ask them what's going on, and I'll say, patient states they were never prescribed a statin. Patient states they were never told to take a baby aspirin. And perhaps maybe they were, but maybe they thought it was something that would be sent to their pharmacy, but you can actually get it over the counter, and maybe they didn't understand it. Like there are a lot of layers in terms of what can happen with these recommendations that come from someone, whether that's verbal, whether that's printed out on your DPART summary, maybe it wasn't actually discussed with you. There are a lot of layers in this, right? So I prefer to just ask the patient what's going on with it. If they were not prescribed it before, if that's what they tell me, that's what I write in their chart. If they if there's some specific barrier, whether that be financial, whether that be just lack of access, maybe they're not close to, the distance from the clinic to their home is quite far and there's no pharmacy in between, maybe that's the reason that they just don't have time to go pick it up when they're relying on Medicare transportation, or they're relying on a few of my patients rely on like neighbors to bring them to some of their appointments as opposed to family members. We have to think about those things and how can we better serve our patients to make sure they're getting access to the things that they need, realistic access to the things that they need. Also, I think utilize it when feasible and when funding is obviously available. Utilizing some of these mailing prescription pharmacies has been very beneficial for some patients. It takes all that out of the picture. That going to the pharmacy. I mean, I think of myself. I go to my local CVS down the street. It's kind of annoying. You have to wait in line. You're kind of like, they want to give you some education. I already know I've been on this medication forever, like it's all these things, right? So it's just, there are a lot of layers, there are a lot of barriers, but I prefer to just write what the patient told me.
That's such an amazing point. I just want one thing to tag on, Kristen, before we go to our next question. With the, there's a couple different things we can use for the patients to try and help them to figure out where a cost-effective option for medications are. One is the Good RX app that you can go to, and it will tell you, like in your local area, that this person could go to this CVS, 2 blocks away, and it's $400, but they could go to this Walgreens, 2 miles away, and it's going to be $100. And then there's another pharmacy that you probably might have heard of, this a guy named Mark Cuban, who's on Shark Tank, and like he's kind of a famous dude from that. But what he has done recently is developed a pharmacy called Cost Plus Drugs out of Texas, where it's all generics, but who cares, quite frankly, like if they need the meds, but it is at cost basically. And so I can just give a personal example where I was trying to get a prescription for Zofran for myself for my migraines, and Blue Cross wouldn't cover it. It was gonna be $200. I got the same prescription for $20 mailed to me in 2 days from there. And so we use Cerner for our EHR, and you can prescribe directly from all major EHRs to there, and they will you can search they have hundreds of medications. So I have no stock. I don't know Mark Cuban. It's just an option that we can use for our patients, but it's Cost Plus. You have to look up as like Mark Cuban Cost Plus Drugs and Cerner. I'm assuming Epic is the same, but they use the major pharmacy prescribing option. And so that's been kind of a godsend for some of my patients.
Mm-hmm. I want to circle back to, one of the questions that was asked about representation. I think that, I think one thing that, so me as a surgeon, one thing that me and people who are other surgeons don't really think about, and certainly don't leverage as much as we need to, are everyone that works in the clinic with us, right? Yeah, I know I'm preaching to the choir here, but everybody that works in the clinic with us. And I think about an encounter that I have with a patient. Before I even go in that room, my nurse Stephanie, she'll say, hey, Olamide, this patient, they had a really bad day today, or they lost a family member the other week, or this is going on, or they're telling me about their foot, they're saying that the pain's even worse, blah blah blah. I just took down the dressing, there was some green stuff on it, like there's so much that you can learn in that interaction with the person who's sitting right next to you, and interacting with the patient as well. The same thing is true with our registered vascular technologists, the RVTs. they learn a lot from these patients while they're scanning them, while they are doing the ABIs, et cetera, et cetera. So representation doesn't always have to be the vascular surgeon in the room. It doesn't always have to be the cardiologist. We don't need, 40% of our workforce that is specific to cardiology or specific to vascular surgeons, et cetera, to be Black or to be brown or to be, American Indian, anything like that. We need our workforce to look like the population. And that's from all areas.
Right. I love that you're enabling your nurses and your RVTs to have that dialogue with you. And it's so very important. We have another question from Tad, and we're going to unmute him to ask it. Hopefully this works. Let's see.
Can you hear me?
Yes.
Yes.
Hi, Tad.
Hi, Dr. Alabi. Wonderful presentation. Just to up front. So I guess I'm Caucasian of Polish background, immigrant, displaced in England, and then an immigrant to Canada. So, and I'm a dermatologist who spent more than a quarter of a century doing wound care. So a lot of what you say with regards to social determinants and care is applicable to the population I looked after, which I would say was probably 75% would be qualified as white and 25% Black or Asian as well. And I agree with you that a lot of those social determinants are equivalent, and a lot of the people who look after wounds, and I think some of the colleagues on the would agree that a lot of people who have bad wounds have a lot of social economic problems. And so I think it's not just related to color. That's number one. Number two, I would agree also that bias that I love the little icebreaker picture there. I think a lot of it, some of it is, I think everybody knows that bias is not an uncommon thing in society. It's you come to a country, you're a minority. I was a Limey Polak and this sort of stuff. And, so these things, some of these things, what doesn't kill you makes you stronger. But those things are to be expected in society. I don't think we can wipe that out, but we have to be cognizant. But I agree that there's a bigger part of bias under the water, which is sometimes subliminal. I don't know if you can answer that, but coming from a Nigerian background in Africa, one of the criticisms we have in dermatology is that too many of our pictures in dermatology books are white, or at least Caucasian, and not Black. Though that's rapidly changing, I must tell you. The narrative in the last decade has been so strong that the emphasis has been certainly pushed that way, which is good, because recognizing color, maybe that toe was probably a lot worse than they thought, may not have been as bad because of the color, right? It's a difficult thing to perceive. But I'm just wondering, I've always wondered, I'm sort of always a bit scared to ask, but what happens in say African countries or South American countries where the predominance of the population is Black, right? What happens to the minority who may be white or Asian, Indian, maybe, I don't know. What happens to that population in those countries? How is that affected? Do they have similar problems to what the Black population, say we're just calling it Black for today, has, say, in North America, say, including Canada?
Yeah, excellent points and excellent question. I can't say that I'm an expert on global disparities in PAD care. But what I can say, just from anecdotal experience, both as a child of immigrants from Nigeria and from having done some global missions in Nigeria, as well as Rwanda and as well as Malawi, a lot of the expats may be white patients, maybe Indian, maybe Chinese, various different ethnicities that are not, characteristically Black. But those patients are usually funded. And those patients are usually fare pretty well in terms of their health compared to the general population. So we don't see, in general speaking, we don't see inverse disparities in that regard in populations that are majority Black. Mhm. And, really great points that you made about these pictures as it relates to dermatology. What does this particular rash look like on melanated skin? What does cellulitis look like on darker
Yep.
hues? Things like that. I can tell you, some of my trainees and some of the students are not familiar with being able to identify lower extremity cellulitis on a black leg. And it's no fault of their own. It's just not something that they're comfortable with or used to. But a lot of these resources that are, as you mentioned, being created now and now are publicly available on various websites, make it a lot easier for you to be able to distinguish what should this look like on skin that looks like, what has not been traditionally the majority. And, very great point.
Yeah, we're developing clinics all the time with clinics of skin of color and trying to emphasize that point. I think we have been lacking in doing that in the past.
Mm-hmm.
Thank you very much for a great presentation.
Yeah, thank you for your questions.
That was a fantastic question. Teresa Ustanik has a comment, I think going back to a couple of topics ago, that some insurances have medical assistance programs and WellMed is one of them. And so I think that is something that, we all can look into as well to see. And I think that there are some community health workers who can help us with some of I know that a lot of my Medicaid options will have that. And her other comment was, what a wonderful presentation. And then there is a question from Donna Bailey that said, I hope there will be a replay. I would really love to forward this to the doctors and chairman of the wound care center that I work in. The population we serve is approximately 80% Black and brown. So I agree. This has been phenomenal. We will work to get links posted on our websites. And her question specifically is, how do you manage the pain from PAD?
Yeah, which can be quite tricky. So, of course, there is ischemic pain that requires a revascularization. And you would imagine that pain will either resolve or at least significantly improve with revascularization. But then there's always the pain that's associated with these wounds or the gangrene or the post-toe amputation or et cetera, that is not specifically ischemic. And then now that you've gotten source control, it's not specifically infectious. What do you do with that? And so there are a number of different ways to approach it. Kind of some of the things that we do in concert with our podiatry team is try to determine, does it seem as though this pain is or might be neuropathic? Some element of it might be neuropathic. And perhaps a neuropathic agent might be more beneficial for those patients, whether that be gabapentin or Lyrica, et cetera. Is it muscle fatigue, or is there a muscle related issue? We can see a lot of this, so we don't really notice it all the time, or I think historically we haven't, but after a leg bypass, you're cutting through a bunch of muscles and separating a bunch of things to get down to an artery, right? And now tunneling a bypass, whether that's a vein or whether that's something a little bit more sturdy like a PTFE graft to tunnel these bypasses. And so now you have these things that are now in locations that were not previously there, displacing tissue in a way that was not displaced before, right? And there can be growing pains, if you will, after an operation to learn how to walk on your leg again, even if you don't have a ulcer or a wound or gangrene that got an amputation on your toe, right? So there are a lot of different ways that we have been working with our pain colleagues as well as our podiatry colleagues to be more aggressive about treating neuropathic pain, be more aggressive about treating hyperglycemia or glycemic indices in patients who are diabetic, or diagnosing their diabetes if they didn't know they were diabetic and they came in with these problems. We are being more aggressive about some non-medicinal agents that our pain teams are using, whether those be specific types of regional blocks, nerve blocks, or just adjunct medications that are non-opioid and non-neuropathic agents. So I think really working with a team of individuals to try to treat these patients is really the best approach. I think, giving them just oxycodone, just trying to figure out, does the 2.5, does the 5 or the 10 work? Isn't it, right?
Yeah, no, I totally agree with that. And I think that one of the challenges that we have also is that, you'll have the patient with the massive FemPop distal bypass, and they'll be given 7 tabs of oxycodone to last them until their post-op visit in 2 to 4 weeks. And then everyone's surprised when they call in 3 days and say, I need more pain medicine. So I think that's a huge challenge. Well, we are just about out of time. This has been phenomenal. I just want to thank you so much. I've learned a ton. I know that all of our attendees did, and people that watch the replay will as well. On behalf of AAWC, I want to thank you for joining us. And our next webinar for AAWC is on October 25th. We're talking about skin tears, and it's co-sponsored with the International Skin Tear Advisory Panel. So we'll have panelists from globally, which will be great. And it was a pleasure to have Tad joining us from Canada, and hopefully with some other people from outside the US. And Kristen, any last thoughts to wrap up? And then Karen.
No, I've just really enjoyed this. I've enjoyed this discussion and the questions and the insight that you bring on this very challenging population that all of us just keep striving to do our best at and help these patients out. You know, Society for Vascular Nursing has been around a long time, and I love that we're partnering with all of you people. And if you're providers and you want your nurses to join, please, you know, look into that. If you're a provider and you want to join, please think of us too. We're trying to do this every month. Our next topic will be on writing abstracts and submitting abstracts for publication. We have a very dedicated practice and research team who's going to be leading that very, very casual discussion. So please join that. And every month we'll have something coming up that's free, just like tonight. And I thank you so much for your time. It's just been invaluable.
No, thank you guys so much for having me. I look forward to more content with SVN as well as AAWC, just listening and learning. You know, I'm happy to be on this side, but happy to be on the other side as well. And I think, you know, just for everyone in the audience, I think just really making sure that we are not trying to make the case for keeping everything in perspective. We're not trying to make the case for PAD. We're not trying to make the case for, you know, healthcare disparities per se. We're trying to make the case for patients. We want to do the right thing for patients. And I think if we all keep that on the forefront of our minds, these are our patients, these are our friends, our family members, our neighbors. That's who these patients are. I think we can get a lot further.
Yeah. Thank you. Everyone have a wonderful evening and enjoy those beautiful fall colors wherever you are.